All right, so I have the pleasure of being your last person to present. So hopefully everyone's awake and alert because we're going to be talking about medication administration via an enteral access device. I have no commercial relationships to disclose as far as the learning objectives. Define general terms associated with medication administration via an enteral access device. Explain factors that influence drug absorption and bioavailability. Also address some additional influences that may impact medication administration on somebody who's enterally fed, and describe some of the best practices for ordering, preparing, administer medication through an enteral access device. As far as the oral drug delivery, we know it's the most convenient and the most common route of drug administration, and your oral drug dosage forms, whether they're tablets, capsules, or liquids, I hope not a surprise to any here, they're designed to be taken by mouth. And for most oral medications, with rare exceptions, the enteral route is considered off-label, and it's not supported by the FDA or the manufacturer. And if you manipulate an oral drug to give by a feeding tube, you have to take into account gastrointestinal absorption, bioavailability, clinical effect, and safety. And the ultimate goal, whether you're providing a medication orally, enterally, or intravenously, it's for effective drug delivery to a therapeutic site while minimizing the risk of harm. Bioavailability can be defined as the amount of drug that reaches the systemic circulation. As a reference, bioavailability for intravenous medications is 100%. Some of the physiological factors that potentially may lower drug bioavailability if the drug is given by the oral or enteral route includes fractional absorption of drug from the gut lumen into the enterocyte. We have removal of drug by gut efflux transporters or enzymatic breakdown. And we have removal of drug by hepatic transporters and enzymes, collectively referred to as first pass effect. Drug absorption can be defined simply as the drug crossing the apical membrane of the enterocyte and is determined by both drug solubility and drug permeability. I think it's important that we differentiate between absorption and bioavailability. Bioavailability takes into account fractional drug absorption across the enterocyte, as well as the impact of efflux transporters and metabolizing enzymes in the gut and liver. So absorption is not the same as bioavailability. Solubility is the degree to which a drug dissolves, and each drug has a defined aqueous or water solubility, and simply the reason of why some drugs may require more water than others. Major determinants of drug solubility would include gut-specific factors, and I've given some examples like motility and pH, both gastric and intestinal. Drug-specific factors like particle size, with smaller particle size preferred. And then we have product excipients, and excipients is any substance other than the active pharmaceutical ingredient. And poor soluble drugs may form a dispersion, and this where you have the drug particles are dispersed in a fluid rather than dissolved into a solution. Drug permeability can be defined as the ability of a drug to pass across the gut epithelium in a given environment. It can be passive carrier mediated, and for most medication is actually transcellular. And the major determinants of drug permeability would include selectivity of biological membranes. We also have intestinal region specific transporter expression, so we can think of prodrugs, and then inter-individual variability of GI function, like motility. And some of the factors that influence or that favor high drug permeability would include the lipophilicity, small molecular weight. We have affinity for uptake transporters, as well as reduced gut lumen osmolality, specifically for liquid medications. Gastrointestinal dysfunction. Anticipated absorption of a medication is based on the administration of an intact dose, not modified for enteral administration, in healthy adults with the functional GI system. And this is not the patient that we help care for, correct? And drug absorption in the stomach is limited, but we know that drug absorption in the stomach, while limited, influences intestinal drug absorption and is dependent on the gastric emptying rate. We have gastric fluid volume if you're in the fed or the fasted state, as well as drug co-administration. GI dysfunction may significantly change the intended therapeutic effect of an oral drug administered via an enteral access device. So it's important that we keep that in mind. Food-drug interactions, they're not less important than drug-drug interactions, and can be, it simply is the influence of food and the bioavailability of drug. And some of the mechanisms by which food may impact drug bioavailability include delay in gastric emptying. We have changes in gastric or intestinal pH, stimulation of bile flow. Now that I think about it, stimulation of pancreatic flow, stimulation of blood flow to the liver. And for the pharmacists here, we can think of the impact on blood flow to the liver and first pass extraction is attributable kinetics. And then we have the interaction of the drug with the food itself. And this is where the drug will chelate with ions and potentially influence both absorption and ultimately drug bioavailability. And absorption of a drug can be affected by the calorie content, nutrient composition. You can think of a low or high fat meal, volume, food temperature, as well as the amount of fluid ingested. And oral drugs are evaluated for the presence of a food effect, meaning does food increase or decrease the bioavailability of food prior to FDA approval. And in the guidance on food bioavailability and the fed bioequivalence studies, the FDA recommends that oral drugs are given both in the fed and the fasted state. And the reference FDA meal is a high-fat meal. You see it's a 1,000-calorie meal with 50% of the calories coming from fat. And a food effect, meaning increasing or decreased bioavailability, is considered if the 90% confidence interval for the population means fed and fasted, for your peak serum drug concentration, Cmax, and area under the curve AUC fall outside the bioequivalence criteria of 80 to 125%. And if you're a drug designer, there are challenges. Challenges do exist in the development of drugs that exhibit food effects, right? Because we have varying fat content, right? Not one size fits all. You can have a low-fat meal or a high-fat meal, as well as interpatient variability, and we talked about gastric motility. And a clinical plan may require control and or monitoring of food intake in relation to drug absorption. As far as FDA's biopharmaceutics classification system, its objective is to predict an in vivo performance of a drug product from in vitro measurement of permeability and solubility. It's easy to measure a drug's permeability and solubility, and based on that, to determine what impact, if any, food will have on that. So if we could see the 4 classes, the BCS class 1, 2, 3, and 4, and we're looking at the effect of food on the direction of change and the extent of drug exposure as a function of BCS class. I had to put that on the slide because I was like, there's no way I'm gonna remember that whole thing. But for example, for class 1 medications, we can see they have high solubility, high permeability. Food is not expected to impact bioavailability. For class 2 drugs, we see that they have high permeability and low solubility. Food is actually expected to increase bioavailability. And because we know with food, it's increasing gastrointestinal secretions, right? And we know that we can improve solubility in the presence of excess secretion. And then class 3 drugs, they have low permeability and high solubility, and food is expected to actually have a negative food effect. And in this example, you could think of the food acting as a potential physical barrier, decreasing fractional drug absorption, and ultimately drug bioavailability. In class 4 drugs, few data exist, but what the drug designers try to do, they have a drug that has both low solubility and low permeability, and the drug design process to figure out what they can do to make it act more like a class 3 or a class 2 drug. And this is a prediction, correct? So how correct is this prediction? So Gu and colleagues compared the BCS class to the observed human food effect, and the ability of the BCS system to correctly predict the category of food effect was 80%, which is pretty darn good, right? So 8 out of 10 times. As far as the enteral drug use process, we know that it's very error prone. And I have some case reports that I want to share with you. And the first one, we have a 38-year-old female who presented to the hospital in acute respiratory distress and was diagnosed with pulmonary edema and pneumonia. And after she was initially stabilized, her medications were changed to oral hydralazine, labetalol, and ecpetapine XL. The medication were crushed and administered through a nasogastric tube. The patient developed worsening bradycardia with hypertension and experienced systolic cardiac arrest. She was resuscitated. However, the following morning, they gave her another dose of labetalol and ecpetapine XL crushed by a nasogastric tube. She developed worsening bradycardia with hypertension and ultimately died. So what happened here? Right, ecpetapine XL being crushed, causing excessive hypertension, and then you have the synergistic effect for giving labetalol, which prevents the heart rate to what? To increase. Right, so we have in the second summary, we have with extended release potassium chloride tablets given to a long-term care resident with a history of stroke. I know this is not an enterally fed patient, but I've seen this as well. The tablets were so large, so the nurse crushed them and put them in applesauce so the resident could swallow. And after 10 days, the resident began vomiting a dark brown coffee ground-like substance that had blood in her stools. She was transferred to a nearby hospital's emergency department where she was diagnosed with the GI bleed caused by the crushed potassium extended release chloride tablets. The resident had also been taking warfarin, right, which is an anticoagulant to help prevent another stroke, but the drug had to be discontinued due to the active GI bleed. And as a result, within 1 week of holding the anticoagulant, the resident suffered a second stroke, which left her with permanent aphasia. So these are two examples of how you're questioning extended release medications and whether you're administering orally or through a feeding tube. We can see that one led into fatality and one led to a second stroke, leaving a patient with permanent aphasia. If we look at the package inserts for nifedipine extended release and for potassium chloride extended release tablets, we can see information where patients do not chew, divide, or crush tablets for nifedipine extended release and potassium extended release tablets. It swallow the tablet intact. And there's also warning and precautions of gastrointestinal adverse reactions, right? So it can produce ulcerative or stenotic lesions of the gastrointestinal tract, particularly when in prolonged contact with gastrointestinal mucosa. So if you have a patient who has dysphagia, or if you have a patient who has severe motility problems, are you going to give them potassium chloride extended release tablets? Whether they could take them orally. Is that it? Can anyone answer? No, right? You want to give them liquid, right? So anyone with motility issues should not be getting extended release potassium tablets. Observational studies, we could see in the first one, errors made by nurses related to enteral medication preparation administration approach 60% of doses. And then we have an observational study, which was conducted in an ICU with more than 10,000 doses administered. And you can see that errors related to enteral drug preparation administration was seen in 3/4 of ICU patients, which accounted for more than 50% of all medication errors. Surveys, this was a survey that was done by Joe Bellotta and Peggy Gunther back in 2013. They collected data to assess nursing administration practices of medications via enteral feeding devices and compare that to published standards. And there are 19 questions. It's an eye-opening survey. Obviously, I cannot list all 19 questions as part of this presentation, but two of the questions that I listed on this slide, first one, number 10, is which type of oral tablets do you crush and administer via an enteral tube? Check all that apply. So 95% said immediate release, and then you had 10 to 11% said extended, sustained, or enterically coated tablets. Number 13 is do you dilute liquid medications before administering them via feeding tube? 48% said no. We have yes with sterile water, 13%, yes with tap water, 38%, and yes with another fluid. So whether you're crushing a tablet into fine powder, or you're administering liquid medication, you have to further dilute it if you want the entire dose to make it where to the distal end of the feeding tube and ultimately to the site of absorption, as well as reduce adverse effects related to potentially administering highly osmolar liquid medications. Most of the focus on error prevention related to medication administration has been on nurses, but we need a systems approach which includes everyone who is involved in caring for patients with an enteral access device. Prescribers order drugs, right? We have pharmacists. We perform drug order review. We dispense and prepare medications, specifically hazardous drugs. We have nurses prepare administer drugs at the bedside. What about the dietitians, right? You often identify enterally fed patients for drug orders for oral administration. So this is everyone involved in caring for a patient who has an enteral access device should help in reducing med errors. And enteral drug errors are to be reviewed in a timely manner by an expert committee with recommendations for systems improvements. Aspen published safe practices for enteral nutrition therapy, and we could see that on page 77, there's an entire section of medication delivery via enteral access devices. If you have not read this document, you're caring for patients with who are on enteral nutrition, or have medication administered through an enteral access device, I highly recommend that you review this. And whether you're newly licensed or you've been practicing for 10+ years, I recommend that you have Aspen's enteral nutrition handbook handy. And it does incorporate the medication delivery via enteral access devices into the second edition of this book. It was published in 2019. So as far as prescribing, ideally, the prescriber orders the appropriate drug, dosage form, route of administration, and the correct enteral access device. How often does that happen? And an enteral access device is to be defined by its entry point and its distal end. For example, nasogastric in its diameter. If you have a feeding tube less than 10 French, they're really prone to clogging. So you should only be using liquid formulations. If it's 10 French or greater, you can use crushed or dissolved solid dosage forms as well as liquid formulations. It's really important that you're familiar with the desired final osmolarity. So for gastric administration, it's 500. For jejunal, it's about 285 to 300. As far as the use of electronic medical records with built-in decision support, oral medications that cannot be given via a feeding tube should not be available to a prescriber to order for gastric or post-pyloric administration. And we should also be seeing automatic alerts for patients who have MPO orders or enteral nutrition orders when attempting to order medications for oral administration. So what do pharmacists do? So pharmacists review new drug order appropriateness by evaluating both patient and drug-related factors. As far as patient-related factors, we can see the first question you should ask yourself is the patient able to take medication by mouth, right? Second, are there any anatomical or functional abnormalities in the gastrointestinal tract that may interfere with drug absorption, right? So if you have a primary site of absorption, the tip of your feeding tube is distal to that, are you gonna continue with that medication, or are you gonna look for potential therapeutic alternative? What is the patient's enteral access device, right? Entry point, distal side, and French size. We just talked about that. What is the current status of the enteral access device? Has it been confirmed by chest X-ray? And what is the current enteral nutrition regimen? Formulation, rate, volume, and also if it's a dual lumen device. In terms of drug-related factors, we have the dosage form. Is it immediate or modified release? And also a modification of the oral dosage form change the physical chemical characteristics of the drug. What is the primary site of dissolution and absorption related to where the distal end of the feeding tube is? And as far as liquid formulation, what is the osmolality and viscosity of the product, whether it's an FDA-approved product or a product that has been extemporaneously compounded? Dosage forms are to be avoided if you're opening it like a capsule or crushing it like a tablet, significantly changes the release and absorption of the active ingredient or results in hazardous exposure. As far as type of smaller liquid medications, we need careful consideration related to the distal end of the feeding tube. And we know that undiluted administration, so if we have medications with initial osmolality greater than 500, can actually lead to GI adverse effects. And this is when the nurse calls a dietitian and asks for a different formula, right? She's like, my patient is having diarrhea, I need you to give me a different formula. They're on 3 different liquid medications and they're not diluting any of them, right? So is the enteral formula or is the medication? And it's important to know that osmolality of many liquid drug formulations exceeds 1,000, and a lot of it has to do with sweeteners. And another thing you need to ask yourself, do you really need a sweetener for a medication given by a feeding tube, right? These sweeteners are designed for oral administration, so you don't really need to add cherry syrup to something that's given by the gastric axis. And highly viscous liquid drug formulations tend to be problematic for longer enteral access devices with high surface area. So you want to review the appropriateness of the flush protocol. So generally, the longer the tube, the more flush you'll need to give. So if you have a standard 30 ml flush, and if you have a nasojejunal tube and you have a highly viscous medication, you may have to give twice that flush volume. When we think about solids and order preparation, enteral drug order preparation can be done by pharmacists, nurses, or caregivers in the home to change a commercial oral dosage form prior to enteral administration. So solids, I'm going to say this probably 5 times, only immediate release dosage form should be used for enteral administration. And then keep in mind that not all immediate release dosage forms, hazardous drugs, can be reduced to fine powder. And for hazardous medications, they're to be prepared by trained pharmacy personnel in compliance with OSHA regulations, NIOSH guidelines, and USP Chapter 800 for hazardous compounding. Hazardous medications should not be manipulated by the nurses on the unit. This is something that's manipulated by the pharmacy and delivered to the nurse for direct administration. Closed systems offer an alternative to bill crushing for hazardous drugs if The tablets disperse easily in water. More than 70 to 80% of tablets for immediate release tablets disperse within 5 minutes. And there's high risk for cross-contamination if co-crushers are not cleaned between medications. Here's some medication that should not be crushed. ISMP no longer publishes a do not crush list. This is a list that I came across and it was published in February of 2023. Again, it's a partial list and it's going to include medications that are modified release as well as hazardous drugs. This is something you should have handy as a reference at your desk while you're managing these patients. As far as the NIOSH list of hazardous drugs, it includes drugs used for cancer chemotherapy, antiviral drugs, hormones, bioengineered drugs, which are targeting a specific sites, and then we have other miscellaneous drugs. So if any newly approved medication has safe handling recommendations in the package insert, it would automatically make it on the NIOSH list. And some of the drugs considered hazardous exhibit one or more of the following characteristics in humans or animals. We could say they could be carcinogenic, teratogenic, they can cause reproductive toxicity, organ toxicity at low doses, or they could be genotoxic like chemotherapy, right? Or any newly approved FDA medication that has a similar profile to a drug that's already on the list. Please note that some drugs defined as hazardous may not pose a significant risk for direct occupational exposure if the formulation is not altered. For example, the coated tablet. And crushing tablets or opening capsules should be avoided, and liquid formulation should be used when possible, as long as properly diluted. And there's guidelines for the safe compounding, administration, disposal of hazardous drugs that have been developed by various organizations. Here's what just the example of the 3 different groups, or group 1, group 2, and group 3. So you can see group 1 is antineoplastic drugs like canastrozole, group 2, non-antineoplastic drugs like carbamazepine, and group 3 are drugs that primarily pose a reproductive risk to men and women who are pregnant or breastfeeding. I think it's important to note here that a group 1 drug, we can see that anastrozole, it's FDA pregnancy category X, right? So you can see that in addition to being a group 1 drug, it could also pose a reproductive risk to men and women, right? And women who are pregnant or breastfeeding. Same thing for group 2 drugs. They can fall in the group 3 category. Liquids, commercial liquid products, whether FDA approved or extemporaneously compounded for USP Chapter 79 standards. Anytime you think of a liquid medication, you need to think about the osmolality of that medication. And you can see that most available oral products incorporate flavoring vehicles, right, which contributes to the final osmolality and viscosity. Cherry syrup, what's the osmolality of cherry syrup? It's greater than 6,000. And we talked about the desired osmolality for gastric administration being 500 and about 300 for administration via the J-tube, right? So in many cases, the immediate release dosage form may be more appropriate than the liquid formulation. So for example, Tylenol, you can see the Tylenol solution is suspension. The solution has an initial osmolality of greater than 4,000, and the suspension has an osmolality of greater than 6,000. So if you had a choice between an immediate release Tylenol tablet or a Tylenol suspension, which of the two would you use to give via feeding tube? The solid dosage form. So just because you have a liquid formulation available does not mean that you should use it. So drug dilution, whether it's dry or liquid, it's critical to ensure drug delivery, GI absorption, and to minimize occlusion risk. USP requires purified water, and purified water does not mean sterile water. Sterile water is an example of purified water, and USP defines purified water as free of chemical and biological contaminants following source water selection, distillation, and filtration. Drinking water is not recommended because it may contain contaminants. And a dilution volume of 50 to 30 mLs of purified water is adequate for a powder drug. The volume required to dilute liquid medication depends on the desired degree of viscosity and osmolality. And a general rule of thumb, a 1-to-1 volume dilution seems adequate for viscous suspensions, and a 1-to-10 volume dilution may be necessary for liquid drugs with high initial osmolality values. I think this is a very useful tool that you can use in your practice if you're not now, is estimating the dilution volume for hyperosmolar liquid medications. Sometimes you have to give a liquid So you can calculate the final diluted volume, you can subtract the dose volume from that, and that will tell you the volume of diluent to add. So the example I have here is for a cyclovir oral suspension. You can see the stock concentration is 200 milligrams per 5 ml. Osmolality is 4,200, which is very high, and the order dose is 200 milligrams. So you take the initial osmolality divided by the desired osmolality, let's say 300, if you want to administer that via a jejunal tube. And then you can calculate the dose volume by taking the dose divided by the stock drug concentration, and that will give you the final diluted volume. Then you subtract the dose volume for the final diluted volume, and you get a number of 65 ml for a 200 milligram dose. And that does not account the initial and post administration of a flush. So would this be appropriate for a volume restricted patient? Well, it's ordered more than, for most, it's ordered more than once a day. And then you have to flush, yeah. As far as labeling and dispensing, I couldn't really summarize this, but when you label the medication, you want to use patient identifiers, the name of the drug using Tolman lettering, the dose of the drug, the date and time of the dose, manufacturer and lot number, the beyond use date, using USP 7995 standards. And if it's an extemporaneously compounded product, the organization's compounding record number. You want to fix the label to your syringe, and then you want to provide this. You want to dispense the medication with appropriate directions for preparation and administration. As far as administration, one thing I want you to notice: the enteral feeds are not held; they're held but not disconnected during enteral drug administration. So you're holding, but you're not disconnecting. And new enteral access devices do require an infant compatible syringe or a multi-port adapter for large bore or gastric or nasogastric tubes. And you'll also want to make sure they provide the appropriate tube irrigation, and I kind of listed it out here for you. So you stop the feeding prior to tube administration, flush with at least 15 mL of water, administer the medication with a clean enteral syringe, greater than 20 mL with an MFIT device, flush again with 15 mL of water, repeat with the next medication, and then we'll flush the tube with one final time with at least 15 mL of water to clear any residual drug that's sitting on the inner lumen of that device. And then you restart the enteral feeding. You're not to add drugs directly to enteral feeding formula because it does affect the physical chemical properties and drug bioavailability, especially with open containers. And if we go back to that 2013 survey that Joe Pilato and Peggy Gunther did, 21% of nurse responders added drugs directly to enteral feeding formula. So you want to administer each drug separately through an appropriate access. So if you have a PEG J tube, you would use the gastric port for the medication and the J port for the enteral nutrition. You want to avoid mixing different drugs in the same enteral syringe due to risk of incompatibility. And you always want to consult your pharmacy with any concern related to food-drug interactions. There are drug monographs, and they will tell you whether you need to hold the feed and for how long before and after drug administration. And the one thing I want you to keep in mind is that prolonged feeding interruption to accommodate drug administration increases the risk for inadequate delivery of nutrition. You see that all the time. And holding feeds longer than the time needed to flush an enteral access device and administer each drug must be supported by data. It needs to be solid data. You're not just holding it. You need to make sure that you have data to support doing so. And in summary, most oral drugs are not approved for the enteral route and may not behave as expected. GI dysfunction can alter the intended therapeutic effect of an oral drug if it's given via a feeding tube. We talked about modified release dosage forms that should not be crushed. If you remember the case summaries, administered via an enteral feeding tube. Hazardous dosage forms are to be prepared by pharmacy, not by the nurses on the unit, in compliance with guidelines and professional standards. Commercial oral liquid products with high osmolality may lead to GI adverse effects. And for many, as we saw with the acetaminophen example, the IR solid dosage form is the preferred alternative. Just because you have a liquid formulation does not mean you should use it for administration by an enteral access device. You want to administer each drug separately and do not add drugs directly to an enteral feeding formula. And in the absence of data, you want to consult a pharmacist with any concerns related to drug preparation administration, because they can evaluate the physical chemical properties of the drug and help you make an informed decision. As far as the assessment questions, I have some true and false questions. First one being modified release dosage forms should be crushed prior to administration by an enteral access device. True or false? Good. If somebody said true, I was going to run out of here. So hazardous drugs should be crushed by the nurse on the unit and diluted with tap water prior to administration by an enteral access device. All right. That is false. Bioavailability can be defined as the amount of drug that reaches systemic circulation. That is true. Enteral feeds are held but not disconnected during enteral drug administration. That is true. Thank you.